All right, next up is Clair Blackadder. She's a member of the Epi Analytics team at Janssen Research and Development. Her research interests include prediction modeling and data integrity standards. As a member of OHDSI, she's the project manager for the Common Data Model Working Group.
All right, good afternoon. As Melanie mentioned, my name is Clair Blackadder, and I'm going to be taking you through our study looking at bleeding risk prediction models. So when we think of a serious condition like bleeding, it's really important that a patient know their risk of developing a major bleed, particularly when considering beginning a new drug regimen. So luckily for us, there actually have been models created to calculate this risk. And what we wanted to look at during the course of this study were how good are these models that are currently out there, and can we do any better? So as Jenna showed us this morning, when we approach a prediction problem, we want to really frame it up in the OHDSI way. And how that looked for us was amongst new users of warfarin or direct oral anticoagulants with a prior history of non-valvular atrial fibrillation, bit of a mouthful, but that's our T. Who among those will develop the outcome of a major bleeding event, our O, within a year of the start of treatment? And that is our time at risk. So given that this is the problem we were interested in, we decided to choose some existing risk models that also looked at similar questions. So these were Atria, Hasbled, and Orbit. And we also decided we wanted to look at CHADS2 and CHADS2 VASC. And now you're probably telling me in your head, Claire, you're wrong. CHADS was developed for ischemic stroke. You are right, but there actually has been some research out there that shows that it's also predictive of major bleeding events as well. So in order to answer the question, how well did these risk scores actually work, we applied the 5 scores to the target populations across 4 large US claims databases. And then to answer the question, how can we do any better, we then learned a regularized Lasso logistic regression model on those same target populations across the same 4 databases. And what that allowed us to do was then compare the performance of the existing models and our learned models. So if we focus specifically on the model we learned on the Optum DoD database, predicting major bleeds in new users of warfarin, we had a target population of about 132,000 patients, of whom 3,700 went on to develop the outcome. Within that target population, we fed Lasso about 109,000 different covariates that we wanted it to consider in our final model. So if you look at this graph here, the x-axis shows the proportion of those covariates in patients without the outcome, and the y-axis shows the proportion of the baseline covariates in patients with the outcome. So any of these dots, each one representing a covariate that falls above this 45-degree line here, would be considered a positive predictor, and any dot falling below that 45-degree line is considered a negative predictor. So if we think back to our risk scores that we're interested in, for example, Hasbled, they started out with about 20 to 30 covariates, and they ended up choosing 9 that you can see here, many of which that fall along that 45-degree line, so indicating to us that maybe they're not the most predictive, and clearly there's some room for improvement here. If we look at the additional 4 models we were interested in, they had similar performance in terms of their covariates and where they fell. So the question then becomes, what covariates did the Lasso algorithm choose? So of our 109,000 covariates, the Lasso algorithm chose 455. And yes, that is a little bit more complicated than those models that have between 5 and 9 covariates. But what comes with that complexity is the ability for us to use so much more of the data that we have at hand. So now the burning question is, how did this actually work? So if we take a look at the ROC curves, oh, it didn't really show up right. If we take a look, at the ROC curves for our existing risk scores here, you can see that they achieve about an average AUC of 0.66, with Hasbled performing the best at a 0.68. Our PLP model achieved an AUC of 0.75. Looking at some specific points along these ROC curves, for example, if we wanted to look at a sensitivity of 50%, meaning that we are identifying 50% of the outcomes, we still are achieving a nice specificity of 83%, whereas Hasbled is achieving a specificity of 65%. More typically, we want to look at how our model performs at the high specificity level, where we only have a 1% false positive rate. And we can achieve that and still find about 8% of our outcomes, whereas Hasbled is only finding less than 1% of our outcomes. Digging into our model a little bit more, you can see our ROC curve again here on the left and our nice calibration plot here on the right. And one of the major benefits to using the PLP framework is that we were able to take that optimum warfarin model and apply it to the additional 3 databases we were interested in, giving us a nice external validation. And you can see the model still holds up, even in these disparate populations. And so it really gives us confidence that our model is robust. So in the end, what we found is that our PLP models that we developed using the patient-level prediction package consistently outperformed the risk scores that are used in clinical practice. And this really lends further credence to the argument that the PLP framework is really how we should be approaching all prediction problems in the future. Thank you.